Hello, everybody, and welcome to the Thrombosis Canada program in partnership with World Thrombosis Day and Thrombosis Ireland. We have a great program this evening that is called Cancer-Associated Thrombosis, What Patients and Caregivers Need to Know. I'm Lena Castellucci. I'm a general internist and thrombosis physician, and I am based in Ottawa, Canada, and I'll be facilitating tonight's program. And next, I'd like to move on to our faculty for this evening. So it's my pleasure to introduce Dr. Cynthia Wu, who is a hematologist and thrombosis specialist in Edmonton, Canada. And Dr. Wu did her medical school and internal medicine residency training at the University of Alberta, followed by further specialty training in hematology and thrombosis at McMaster University. And Dr. Wu is one of our experts in cancer-associated thrombosis in Canada, and she's very active in many of our clinical trials in patients with malignancy and thrombosis. And next, it's a pleasure to welcome Ms. Anne-Marie O'Neill. And Ms. O'Neill is joining us from Dublin, Ireland. And so it is very late in Ireland, and we appreciate that she's joining us live this evening. So we have Ms. O'Neill, who is a survivor of blood clots, and she herself experienced many blood clots and understood the challenge of not having enough information available to her, and realized that this is something that she wanted to change and raise awareness about. And in 2016, she set up Thrombosis Ireland with Shay Kearney, a fellow survivor of thrombosis. And a year later, they achieved charitable status of the organization. And they have made it their goal to ensure that patients and their family members are apprised of risk factors and signs and symptoms of thrombosis to watch for. And they've also made it a goal to ensure that physicians and other healthcare providers are educating their patients about thrombosis. And so it's great that we can have Ms. O'Neill here with us tonight to provide that experience and that expertise for us. And lastly, I would like to welcome Dr. Claire McClintock, who joins us from Auckland, New Zealand. So not quite as late for Dr. McClintock. It's midday in New Zealand. And we very much appreciate having Dr. McClintock with us. She is an obstetric physician and hematologist at Auckland City Hospital. And she has special interest in women's health and, in fact, in pregnancy-associated thrombosis and many of the complications related to that. She has extensive experience in thrombosis and is our most recent past president of the International Society of Thrombosis and Hemostasis. So it's with great pleasure that I'm surrounded in excellent company this evening for our presentation today. Just so that we are being thorough and complete, this slide includes our disclosures, and so I'll leave that up there for a moment for our viewers to take note of. None of the disclosures are relevant for this evening's presentation. And forgive me, I keep saying evening because it's evening for me in Ottawa, but I do appreciate that people are joining us from all around the world. Our learning objectives for today are listed here. So what we would like participants to take away from the program is to know what the signs and symptoms of thrombosis are, to be familiar with the risk factors of cancer-associated thrombosis, and to be able to discuss your thrombosis concerns with your healthcare providers in a confident manner. And so we hope that you can take a lot of information away from our program today. And next, I'd like to pass this over to Dr. Wu.
Thank you very much, and thank you for everyone for coming in. I have the task of spending the next few minutes just discussing a little bit about what thrombosis is so that we're all on the same page as we move forward through this presentation. If you could please advance the slide. So this graphic here I thought was actually quite a very useful graphic to have. It shows red blood cells, which are those little red dots zooming through like cars on a highway and then running into a bit of a traffic jam, either an accident or maybe just extra traffic there. And thrombosis is the medical term that we use to describe a blood clot, and a thrombus is the actual blood clot itself. And when blood clots form, it's exactly like this traffic jam situation where blood cells basically start to stick together at the site, usually of an injury, but not always, as we'll discuss through these other medical conditions. And it blocks off blood flow. So very similar to cars on a highway, you basically have a decreased amount of flow through that area. Next slide, please. So there are a lot of infographics that are out there that help us give you some more information about why blood clots are important. But probably one of the most striking things to understand is a lot of people have heard of disorders like heart attacks and strokes, and those are what we call arterial blood clots. But far less people have heard of the venous blood clots, which are what we're going to focus on today. And for the remainder of this talk, we're going to try use blue blood vessels to represent veins, and the red ones are the ones that represent arteries. But it is a very striking statistic that 1 in 4 people across the world end up dying from blood clot related disorders, which do include this thing we call venous thromboembolism, or VTE for short. Thrombo referring to thrombosis, as we mentioned on the last slide, and embolism being a blood clot that has moved. Next slide, please. So what do you need to know about thrombosis? Why is this important? Next slide, please. This little graphic put together by Thrombosis Canada sums up some of the most important statistics that you can get out. The first, again, highlighting that 1 in 4 deaths can be resulting from a thrombotic or a thrombosis-related disorder. Within Canada, to make it a little bit more local, about 10,000 deaths in Canada are caused by thrombosis, and about 100,000 Canadians are affected every year by thrombosis. Of all of these, a large proportion, probably at least half, if not a little more than half, are related to hospitalizations of some kind, either a medical hospitalization or a surgical hospitalization. And as we'll go over a little bit more detail in the remainder of this discussion, one of the biggest risk factors is cancer, and unfortunately, clot is the second leading cause of death in cancer patients under cancer itself. Next slide, please. So these graphics here just give you a bit of an idea of when we talk about venous thrombosis, while there are veins in every area of the body, the majority of the time we are focusing on 2 different sites. One of them is the leg, which we will now refer to as deep vein thrombosis, or DVT for short. And again, the blue side kind of represents veins, and the red side is more the arteries, which we will not be talking about today. And that little blow up portion under deep vein thrombosis just shows that inside veins we have little trapdoors that we call valves. And oftentimes the blood clots either grow through or get stuck in those areas because of the turbulent blood flow through those little doors. Sometimes, unfortunately, though, as blood flows up out of the leg and into the rest of the body, a blood clot can be picked up and then it gets moved out and travels around, eventually getting pumped out into the lungs, which is the second half of this picture. And we call blood clots that get stuck inside the lungs a pulmonary embolism, or a PE for short. Pulmonary standing for lung, and embolism standing for a blood clot that is moved. And the blood vessels you can see here in the lungs are like the branches of a tree. So eventually the blood clot will get stuck in there somewhere. Big ones right in the middle, like this picture, and smaller ones get pushed out to the side. Next slide, please. So if we take a look at how a blood clot in the leg presents, or a DVT presents, again, going back to the picture of imagining a traffic jam, if you have a blood clot that blocks off blood flow, you can get swelling in that area of the leg. Because the blood clot, the blood veins, I should say, are usually inside the muscles of the leg, you can get pain, almost like a muscle cramp in the leg as well too. And inflammation can occur that causes that warmth and redness that occurs inside the leg as well. Usually only one leg is affected, although on the rare occasion you can get blood clots that affect both legs at the same time. Next slide, please. Pulmonary embolism, or the blood clots in the lungs, are a little bit more dramatic. People can present with shortness of breath, which usually happens all of a sudden since blood circulates pretty quickly. Chest pain, often described as sharp stabbing pain. The O2 stands for oxygen, and your oxygen levels can go down because you can't get the oxygen out of your blood quite as easily because the blood flow is blocked by these blood clots. And tachycardia refers to a very fast heart rate, and just really highlights that especially big blood clots can cause strain on the heart, as the heart ends up pumping faster, and so you can feel your pulse rate go higher than normal. Next slide, please. So there are a lot of famous people in the world, and obviously this slide will only show a couple, but just as an example, anywhere from actors like Jimmy Stewart to athletes like Chris Bosh, and then also athletes like Serena Williams, and even famous politicians like Hillary Clinton. So men, women, old, young, people who are extremely fit and healthy, and otherwise blood clots can really hit anyone. Next slide, please. So risk factors for blood clots, I'll go over quickly, but then of course we'll focus a little bit more on the cancer portion with the next speaker. So this is just a little graphic that shows you all the different things that can cause blood clots. It is obviously going to be a much longer list than this, and I usually like to break it down to 3 big categories of which these all fall into. The first being immobilization, because the circulation in the leg gets worse when you're not moving around, so that includes being in the hospital. We have major injuries, which includes surgeries, broken bones, trauma. The way that your body will stop the bleeding is by clotting, and so that certainly increases the chances if you have a really big injury or a big surgery. And then a long list of medical conditions, including cancer or genetic conditions you might be born with, as well as a whole host of medications, including very common medications like hormonal therapy for women and men, but of course women more frequently on hormonal therapy can also make the blood thicker than other people and lead to blood clots. Next slide, please. So at this point, I will be passing the talk on to the next speaker because cancer is certainly a big risk factor. I think it's very important to focus in on this group of patients. Thank you very much.
Thank you, Cynthia. Thank you. Hi, my name is Anne-Marie O'Neill. I'm patient founder at Thrombosis Ireland. So I'm going to focus on, I suppose, the wording from the patient perspective. So when we're talking about VTE associated with cancer, it's called cancer-associated thrombosis, or CAT for short. So you may hear people talking about the fact that you have a CAT diagnosis. We're going to focus on DVT and PE and the risk factors for CAT patients. Next slide, please. So a clot in the arm. A clot forms when there's a blockage in the vein, usually in the leg and less often in the arm, but usually with the arm if there's a PICC line involved. Incidence in general population is about 1 in 1,000, and 60% of all clotting events happen as a result of a hospital stay. But it's really important to say that the risk remains high for another 90 days after you leave hospital, and most people don't know that. So you need to be really vigilant for 90 days after you leave hospital. The incidence in those with cancer is approximately 1 in 5 or 20%, and this is related to active cancer, cancer therapies and surgery. Next slide, please. So the symptoms, I'm going to repeat, of a deep vein thrombosis or DVT is pain in the leg or arm only with no history of injury. Now, we do have some cancer patients who present with pain in their neck or shoulder, again related to PICC line injuries. So we need to really be aware of that as well. And tenderness, swelling, warm to touch, discoloration. And if you have one or more of any of these symptoms, you may have a blood clot and you need to get urgent medical attention. Do not ignore it. Next slide, please. Then a pulmonary embolism, or PE. A PE normally occurs when a piece of the clot breaks off from the clot in the leg or arm and travels through the bloodstream until it becomes stuck in a smaller vessel, usually in the lung. A DVT plus a PE is a VTE, a venous thromboembolism. So these are words that you'll hear: DVT, deep vein thrombosis, PE, pulmonary embolism. Both of these together will give you venous thromboembolism. Next slide, please. So symptoms of a PE: chest pain, particularly on inspiration, breathlessness, fast or irregular heart rate, feeling faint or dizzy, coughing up blood-stained phlegm, or even sudden collapse. If one or more of these symptoms, you may have a blood clot and need urgent medical attention. Do not ignore the symptoms. Next slide, please. Remember, please do not presume that these symptoms of a DVT or PE are normal for people undergoing cancer treatment. They are not. Act fast and get checked out. It could save your life. So what causes cancer-associated thrombosis? I call it like the perfect storm. It's a triple whammy. You've got patient-related risks, cancer-related risks, and cancer treatment-related risks altogether. So we'll focus first on patient-related risk. So if you have somebody who's of the older age group, 60 plus, immobility because of the illness, overweight, so you need to watch your BMI, existing medical conditions, personal or family history of blood clots. So that's the patient-related risks. So think about that. Do you have those patient-related risks? Next slide, please. The next related risk is the cancer itself. So the type of cancer, like brain, ovary, pancreas, bowel, stomach, lung, kidney, and some hematological cancers are high risk. So the type of cancer will affect your risk. The stage of the cancer, how advanced it is, will affect your risk. About 50% of cancer patients will experience a blood clot in the first 3 months of diagnosis. Tumour cells can release pro-clotting substances as well, and hospitalisation and immobilisation. So remember, if you've been hospitalised, if you needed surgery, then you're still at increased risk when you come out of hospital for another 90 days. It's a really important figure to remember. And I think when we're talking about 90 as well, about keeping mobilised, do the best you can to mobilise yourself every 90 minutes during the day. Even if you're feeling unwell, get up, get the blood flowing in your legs, walk over into your kitchen, make a cup of tea, just move. Have a 90-minute rule, and then remember the 90-day rule after you leave hospital. Next slide, please. And then the third risk relating to cancer patients is surgery is often prolonged, and recovery can be slow with long periods of immobility. Chemotherapy drugs can damage the endothelium lining of the veins. Radiation can damage the endothelium lining of the veins. Chemotherapy drugs can damage the walls of the veins, and central PICC lines are a big issue when it comes to causing thrombosis, because the insertion of them can damage the veins and cause thrombosis. Next slide, please. So now we have a video of Deirdre. She had a recent diagnosis about a year ago of cancer, and then had a blood clot experience. So enjoy her story. She really wanted to share it with you and her experience, and try and help others understand why it's important to inform patients of their risk and the signs to watch for. Thank you.
My name is Deirdre Murphy, and I'm here today to tell my experience of cancer-associated thrombosis. I had no idea that there was a heightened risk of thrombosis with cancer diagnosis or cancer treatment. Realistically, I had no idea about thrombosis or cancer treatment, so it wasn't something that was on my radar. For my treatment, I received 2 different kinds of chemotherapy throughout my diagnosis. My first line treatment was through injections, and nothing was ever mentioned to me at the time about thrombosis or the risk of clotting. And when I moved on to the full intravenous chemotherapy treatment, I was advised I'd have to have a PICC line fitted, and at that point I was told the day the PICC line was fitted that I had a potential risk of developing a clot because I had the PICC line in sight. And I was told to look out for swelling and given a pamphlet when I left the hospital, but that was the only time it was mentioned. So I wasn't too worried. I had thought I had at that stage just an interesting thing had happened with my PICC line. But I did attend for my chemotherapy treatment the following week, and at that point a nurse did notice that she thought my arm looked a bit swollen in comparison to my other arm. She asked me, did I find it swollen? And I said, I suppose, slightly, but it wasn't alarming to me. And I think because it wasn't alarming to me, it wasn't alarming to her, and nothing was done about it. So it was 6 weeks later I had my line removed, and I'd say about a month after that, as I was starting the process of rebuilding myself post-treatment, that I had started to notice that actually the discomfort and swelling in my arm was still present, that the veins in my chest wall, in my shoulder, up into my neck, suddenly were really, really obvious. I looked like I had a lot more here compared to on this side. So at that stage I started to become concerned that something wasn't right. It didn't feel like an emergency situation to me, so it was potentially a couple of weeks before I spoke to my oncologist, and I mentioned I was having these symptoms, and he took it seriously. He said the right thing to do would be to get it scanned. I suppose he also tried to address any fears that I might be having around it, and said, look, he wasn't terribly concerned about it. The line had been out for a couple of months at this stage, and you know, it could just be a lymphedema. It could be just my system coming right again after having had a foreign object in it for the best part of 5 months. So he arranged for me to have an ultrasound with a radiologist. And when the radiologist performed the ultrasound, he did it on this part of my arm. So the line would have been in sight kind of around here, and he scanned this entire part of my arm, and the blood flow was perfectly clear. There was no issue, and the advice was Your arm looks symptomatic, but it looks fine. It could be a lymphedema, but if the symptoms persist, let us know and we can arrange for further treatment. At that point, I was still anxious because he had, in a way, ruled out for me an issue with a clot. So I was concerned of what could potentially be causing the swelling in the veins, and you know, I had enough physical enough of the physical kind of ramifications of cancer and chemotherapy going on at this stage. I was bald. I had, you know, lost weight. I now had like a blue chest. You know, there's a lot that you're trying to come to terms with, and I got fixated on the fact that I had this blue chest and this red arm and no answer for it. So I asked my oncologist who can help. What's the next stage if it's not an issue with my veins? He suggested it might be a lymphatic issue, and that a lymphatic nurse would be a good next port of call. And about a month later, I met that lymphatic nurse in the middle of March, and she took one look at my arm and said, "What you have, Deirdre, is vascular." She could tell by the discoloration, the mottled appearance of the skin, the veins in my chest, and the slight but not dramatic swelling. Again, it was up to me to follow up with my oncologist to say I need further tests to rule something out. The lymphatic nurse believes I have a vascular issue, and they arranged for me to have a venogram. And that venogram occurred middle to late April. And lying on the table, I can still see it right now. I'm looking at the scan, the dye going in my arm, and as soon as it gets here to my subclavian vein in my chest, it just goes nowhere. It starts pushing out into all these lovely new veins that I'd all of a sudden started to see across my chest and my shoulder. At that point, the radiologist told me the vein was occluded. Language I've never heard before. Occluded, I now know means blocked. But the vein was occluded, and I had what he called collaterals. So all these lovely new veins were like tributaries. And I needed to wait a few days for that message to reach my oncologist, and for my oncologist to call me out of the blue and say, "Yeah, it looks like you have a thrombosis." A new word. So thrombosis hadn't been mentioned to me at the scan. And all of a sudden, I got the fear. I got afraid. So we went to meet the oncologist. He was going to give me a prescription, and he explained that there was a thrombosis, probably caused by the PICC line, that the protocol for that would be to go on a 3-month course of oral anticoagulant, and to be rescanned after 3 months. And I was in shock. Because I had no idea what having a thrombosis in my chest meant. I'm not expert in this. The only time I'd ever heard of clots in chests were things like pulmonary embolisms. I didn't think you could get a thrombosis anywhere other than your leg. So if I was a medical professional and I was dealing with a newly diagnosed cancer patient who was about to start out on their journey of treatment, regardless of what that treatment is, I understand now that they are at a higher risk, a 1 in 5 risk of developing thrombosis. So that's, if I'm telling my story today, I'm hoping that another patient doesn't end up going through the same journey that I've gone through.
So what are the patients saying? This is some comments from Simon Noble's trial, the Pelican study, and the patients in his trial were saying, "But they told me you're going to get clots. Nobody told me I was going to get clots after chemo. That's one thing I haven't heard. They never said." I just put it down to my breathing. It's just one item of information that we weren't aware of. The next person said, "But I didn't realise that that was what was causing. Obviously, it's a clot, I know. I didn't have any pain or anything. I just thought I was getting short of breath." Anyway, like, do you know what I mean? Because of the chemo and everything, they just thought they were getting shortness of breath because of the cancer treatment. It's only when you start reading about it that you sort of realise how dangerous clots are. Next slide, please. So patients have said to me in our support services, like, getting a clot was the worst part of my treatment. It was so unexpected. The urgency with which it had to be treated was terrifying. If I had known that the leg pain was so serious, I would have acted sooner. I expected pains and aches. I was on chemo. Next slide. So I'll hand over to the next speaker now.
Thank you so much for that, Ms. O'Neill. We very much appreciate your input and sharing Deirdre's story. That was fantastic. I'm going to continue on and move to the next portion of let's talk about it and make sure that patients and family members are aware of cancer-associated thrombosis. And it's important that both patients and their family members receive education about the risk of getting a clot and the signs and symptoms that we've reviewed a couple of times already during our program. And that repetition is really important to make sure the message is heard. And so we intentionally did that during this presentation. So it's not that we meant to be repetitive and redundant, but we did want to ensure that patients and other participants seeing the program understand what those signs and symptoms are, and they know when to seek medical attention. And we want patients to understand that you get educated about what to do when you get a fever or when you get a sore in your mouth, but thrombosis is also as important as those other complications of cancer and cancer therapies. And so we want to make sure that you're aware of what to watch for and when to go and get medical attention. As Ms. O'Neill explained to us, many people think that their symptoms are a result of either their cancer or their treatment, and so they don't necessarily give them as much weight as maybe they should. And so that's the emphasis that we really want to impart on our participants today. One of the other things that's important to know is that a delay in diagnosis can unfortunately lead to some long-term side effects or consequences of blood clots. So someone, for example, who has a blood clot in their arm that is delayed in diagnosis may have ongoing swelling and discomfort in their arm or even their leg if there's a delay in diagnosis. And so that's why we also want to minimize any irreversible damage that we can. And it's also important that patients with cancer-associated thrombosis seek attention and other resources for help if they're not coping well from a psychological aspect or a mental health perspective. There are resources that are available, and so we want to make sure that we're providing that information to our patients and their family members when they're going through their cancer therapy and other treatments. And so why is venous thromboembolism, or VTE, so serious? And as we heard earlier from Dr. Wu, we learned that it's the second leading cause of death in patients with cancer. And so that's why we want to emphasize the importance of knowing the signs and symptoms of blood clots and when to get help for those symptoms. And as I mentioned, if we get the diagnosis of VTE early enough, then your healthcare providers can provide therapy for it. And that's the next portion that we will talk about. What are the treatments for blood clots? And there are lots of different treatments that are available. There are pills, there are injections. And what we're going to do next is watch a short video to explain some of the different treatment options that are available.
For people living with cancer, one of the recommended treatments for venous thrombosis is injectable blood thinners called low molecular weight heparin, or LMWH for short. These drugs are given by a needle in your belly, very much like how insulin is given in people with diabetes. The injection is given once a day. The dose is based on your weight and how well your kidneys work. These drugs work by stopping blood from clotting quickly. Once you start the treatment, the blood clot stops growing or moving, and the body can slowly start breaking down the clot. Besides injections, there are blood thinner pills. But not everyone can use pills, because there might be an interaction with drugs that you are taking for cancer or other medical conditions, or you might have vomiting or diarrhea that makes it difficult for the pills to work properly. The older blood thinner pill is warfarin, which is still used for treating thrombosis in patients with cancer. It is taken by mouth, but it can be high maintenance. Because warfarin interacts with all kinds of food and many other drugs, including chemotherapy, each person needs a different dose at different times. The only way to make sure the correct dose is being used for each person is to check blood levels often. This can be hard to manage if you are living with cancer. And if the wrong dose is used, you can still get more blood clots or end up bleeding too much. The newer class of blood thinner pills are the direct oral anticoagulants, or DOACs for short. These drugs also work by interfering with the process of blood clotting. These drugs are taken once or twice a day and may require a different dose at different times during treatment. Unlike warfarin, they don't require frequent blood work to check the level of blood in the drug, and there are no food issues related to them. They also begin to work and clear the system when needed more quickly than warfarin. DOACs are usually more suited to people who have a low risk of bleeding in the stomach or intestines, who are not feeling nauseous or ill, or who are not at risk of experiencing diarrhea. Because there are some medications that cannot be taken with DOACs, a pharmacist needs to check for potential drug-drug interactions before you start a DOAC. Some DOACs require a brief overlap with an injectable blood thinner at the start. Once you start treatment for a blood clot, you need to continue taking the medication for at least 3 to 6 months. A shorter period of treatment can mean that more blood clots will occur. Your doctor will see you a few months after starting this medication to make a decision about whether you can stop treatment or you need to continue. That decision depends on what's happening with your cancer, if you are still receiving cancer therapy, and how well you've tolerated the blood thinner therapy. If you experience symptoms of blood clots, get medical attention right away. Your healthcare team can help you make the best choice for you.
So I think that was a helpful summary of the blood thinners that we have available for treatment of cancer-associated thrombosis. And whenever we talk about blood thinners or any medication, really, we also want to be aware of some of the complications or side effects of these medications. And with blood thinners in particular, or anticoagulants, there is always a concern about bruising and bleeding. And what this slide is showing are some relatively common areas of bleeding that some patients will experience. So bruising is very common to the skin, especially if we bump ourselves. Oftentimes patients with cancer may also be receiving medications like steroids, and that combination of being on steroids and a blood thinner can increase bruising and bleeding risk. And so it's important to be aware that whenever you're on a blood thinner, those minor bruising and bleeding concerns may become more obvious. Also important to watch for more significant bleeding concerns, and of course to tell your healthcare providers if you are experiencing any of those, because that might be an indication that maybe we need to stop blood thinners and determine if the risk and benefit ratio is right for you in terms of treating your blood clot for longer than the minimum recommended period of time. So why is it important that we continue to increase awareness about blood clots? And as we've learned throughout today's program, some information that I'll share with you from a Canadian perspective is that we know about half of Canadians are aware that not moving or being immobilized is a risk factor for blood clots, but only about 10% of Canadians knew that cancer was also associated with blood clots. And so there's a lot of education that we need to do to make this more at the forefront, bring it to the forefront, and make people more aware about the association between cancer and blood clots. So to summarize our message for today for the program, what we want people to take from this is to understand that cancer and cancer treatment does increase the risk of developing thrombosis, and about half of blood clots will happen within the first 3 months of the cancer diagnosis. It is important to know what the signs and symptoms of clots are and not to ignore them. It's also really important to know that blood clots can be prevented in many cases, and when caught early can be treated with minimal consequence. So it's important that if you do develop symptoms that you are seeking medical attention to get the correct diagnosis. The timely starting of anticoagulant therapy and focusing on recovery from a psychological perspective is also a part of your care in thrombosis and cancer. And it's very crucial that we have resources available to our patients. And so we'll talk about some resources that are available to people and where you can find those in the next few slides. It's also important to know that when you do develop these symptoms, you want to go and seek medical attention quickly. In particular, if there's any concerns for pulmonary embolism or PE symptoms, those can be very life-threatening. And as Ms. O'Neill mentioned earlier, you want to act fast and go to the emergency department without delay. So as I mentioned, we have lots of resources and where you can learn more about blood clots and treatments and get some more information. So Thrombosis Canada has a clots campaign, and this is a nice slide that summarizes different symptoms, and the acronym CLOTS is used to highlight them. So the C is for chest pain, the L, lightheadedness, the O is for out of breath, T is for leg tenderness, and S is for leg swelling. And then on the right-hand side, a little bit more of an explanation for each of those symptoms or signs. And again, important to go to the emergency department and not to delay if you have these symptoms, because we don't want to miss an important diagnosis. And if you're experiencing these symptoms and you're not diagnosed with a blood clot, there are possibly other things that might be causing those symptoms. So again, it's important to go and get checked out in the emergency department. Other places, so our Thrombosis Canada website is listed here. So it's thrombosiscanada.ca, and we have many resources available on mobile apps. So this is what our mobile app looks like for your phone or for your tablet. And there's different buttons on there that you can go to get more information. If you go to the website itself, I really like this tab that we have, and it's resources for patients and family members. And there's a list of medications that you can search through. And this is an information sheet on aspirin, for example, and we have them for the other antithrombotics or anticoagulant medications. And there's also information that you could even share with family members or even with your family physician or other healthcare providers. So lots of resources that are available, and I encourage you to go to the website and peruse and see what information is valuable for you. Other areas that we have information, so this is provided from Ms. O'Neill, and it's the Thrombosis Ireland information. And again, this is a really nice infographic. The website is listed here, thrombosis.ie. Lots of information, again, highlighting what the signs and symptoms are that you need to watch for, when to go to the emergency department. And then Ms. O'Neill has provided more of the social media platforms that Thrombosis Ireland is a part of. So the website, Facebook, Twitter, and Instagram accounts. And of course, our other partner for this evening is World Thrombosis Day. And so we've listed that down here. It's worldthrombosisday.org. And again, there's lots of resources both for patients and healthcare providers there. And of course, Thrombosis Canada. And so again, I would really like to highlight that this week is special for us as thrombosis physicians because it does encompass and circulate around October 13th, which was yesterday. And so that was a really big day for us. And it's a big week in general where we try to increase awareness about thrombosis for our patients, their family members, as well as our colleagues and other healthcare providers, because it is important that everybody in medicine is aware of thrombosis. And so we do that in particular this time of year, but every day, of course, we try to educate our patients and our colleagues. So thank you very much for participating this evening. And again, I'd encourage our participants to please enter any questions or comments into the chat function. And I invite my colleagues as speakers tonight to please turn on their cameras, and we're happy to answer any questions that people may have. I'm going to stop sharing my screen so that we can all show up here. All right. Excellent.
So far, only one question on whether a copy of the presentation can be sent out. Maybe one of the Thrombosis Canada representatives can help us out there. And then we also have another question. So some doctors appear unaware that DOACs need a dose adjustment at certain ages, body weight, kidney function. How do we increase awareness of this? I don't know who wants to take on the question. I can take a stab at it, or...
On you go, Cynthia.
Sure, I'll go ahead first. So it's a good question, because there's some confusing information out there, since there are different reasons why we use these DOAC or these direct oral anticoagulants, these new pills that are out there. And some of the indications, mostly cardiac or heart-related indications, do require us to know some of these dose adjustments. But interestingly, for VTE, or for blood clots in the legs and lungs, only one of them has a dose adjustment, and the other 3 do not. So I know that does cause a lot of confusion for people, both doctors, patients, pharmacists, and unfortunately, it's really just talking with your doctor to discuss whether or not you do qualify for any dose adjustments, and then we can discuss with you whether that is appropriate or not. So hopefully that answers your question, or if anyone else has anything to add, more than happy to have you jump in.
Well, talking about dose adjustments, I think also if somebody is prescribed a DOAC and they find that it's not agreeing with them, or you know, if they're a woman and they're finding that they've increased bleeding or whatever at their time of the month or whatever, that they don't have to stay on that particular dose, or they don't have to stay on that particular medication. They can go back to their doctor and maybe try something different rather than suffering on in silence. I think that's a really important point.
Yeah, and also following on that one, you know, if a woman does have bleeding with heavy periods when she's on these medications, there are, even if you don't change medication, there are things that you can do that can help modify the bleeding, and medications you can take. Yeah. I mean, I think one of the most important things for me, having listened to the presentations and listened to Deirdre on her video, is that, you know, when you're a person who has cancer, the treatment, you know, first of all the words are new. You know, doctors have a very specific vocabulary that I think we forget, that it might be words that we use day to day, but they can be quite new and quite different and confusing for people with cancer. So I think always trying to put yourself in the place of the person with cancer when you're trying to explain what's going on, and trying to avoid the medical jargon that we use, or giving them an information sheet that explains what the medical jargon is. And of course, that's even more difficult if a person with cancer speaks a different language to you. And so, you know, that's what we, I think, as clinicians and healthcare providers have to constantly think about. And when I think back on my career as a doctor, when I first graduated, these sorts of things weren't so forefront in the minds of practitioners as they are now. And so I would encourage doctors to think about this, and nurses as well. But also, if patients find that they don't understand what's going on, I think we have to give them the power to be able to ask questions, because it is very frightening, a cancer diagnosis. And then if you throw on top of that being diagnosed with a blood clot, you know, it's a perfect storm for fear and confusion and anxiety. And I think that's a lot of our role. So it was wonderful, the presentations that you gave in the videos. I think they were really clear.
Yes, Deirdre mentioned to me after she made the video that when she was diagnosed with cancer, she completely surrendered to her healthcare professionals. She had to hand over that trust for her life, basically, for her treatment, to her healthcare professionals. So she felt she did her part every time she mentioned that she was a little worried about her arm and there was no reaction. She felt each time she kept notes on her temperature and, you know, any symptoms she might have. And when she'd mentioned the arm, she just presumed that they had it in hand, that if it was something big, that they'd notice and they'd do something about it. So she was a little bit angry or, you know, disappointed about that. And you can understand why, you know, she expected action to happen. So I think she feels bad that she didn't push it even more, because she feels like the damage is done because she was left for too long. And I think this is a really good time to kind of reiterate how important it is to act fast. So it's not just act fast to save your life, but it's act fast to have a better outcome, so that your vessels won't be damaged, so that you won't have a post-thrombotic arm or leg where you're left with pain, for the rest of your life. Basically, it's not fixable. You know, if it's left for too long, it's not fixable. It is fixable in the early stages, but it's very hard to fix it after months after the fact, you know. So act fast, guys, if you get any symptoms.
And also for doctors and nurses is, you know, listen to your patients. Another thing I remember being taught in medical school is that the patient will tell you the diagnosis if you listen to them carefully enough. And so we're often very busy and we get distracted as clinicians, but you know, listening to what the person has to say and the symptoms that they describe, you know, it's basic. It doesn't take, you know, really expensive equipment. You know, you just need to put your listening ears on when you're a healthcare professional. And I have to say that sometimes we're not very good at that.
There's a couple of questions that have accumulated. First, for everyone who's not looking at the comments, David from Thrombosis Canada has let us know that the talk will be posted on websites. So will be available, even if you can't get a copy of the presentation, it should be widely available to everyone soon. There are one comment just to remind all our cancer providers, including myself, to describe what a VT looks like and repeat it over time, because the information is obviously hard to remember when you're overwhelmed with the information on cancer therapies and everything else related to your cancer journey. But there's another question here that maybe I'll let Lena jump in, as she hasn't got a chance yet. But if you could please comment on the CLOT study that looked at, this might need a little bit of clarification, but the studies looked at dose escalation of low molecular weight heparin to manage recurrent VT despite systemic anticoagulation in cancer patients. And so at their site, they reduce the dose by 25% of the risk if there's a risk of bleeding, and if there's a recurrent VT, they increase the dose by 25%. And the question was what our experience was on dose increases and decreases.
Sure, thank you. So the CLOT study is an older study now done, my goodness, maybe close to 15, 20 years ago. And it was a study that compared low molecular weight heparin fragment or dalteparin to warfarin for treatment of pulmonary embolism and deep vein thrombosis in patients with cancer. And for the patients that were in the dalteparin or fragment arm, what they received was weight-based dosing for the first month at their full dose. And then after the first month, the dose was reduced by 25%. And they remained on that 75% dose for the next 5 months. So the treatment period was 6 months in total. I think the practice is certainly variable. In my center here in Ottawa, we have a little bit of practice variation. Some people, when they use low molecular weight heparins, will follow that strategy of doing a dose reduction after the first month, whereas I have other colleagues that continue the same dose if the patient hasn't had any bleeding complications in the first month. And I think things that help to guide that decision process are if they have any of the higher risk cancers where we know that the risk of thrombosis is felt to be higher. So as Anne-Marie mentioned, pancreatic cancer, brain cancers, those are cancers where we know that the risk of getting a blood clot is higher. And so someone might be reluctant to do a dose reduction in that particular patient. And so that might be a reason to continue on with the same dosing for the entire treatment period. And then again, if there's also a concern of bleeding risk, that might be the patient where you want to do a dose reduction. So for someone, for example, who has a colon cancer that hasn't been surgically managed, their risk of bleeding is felt to be a little bit higher. And so sometimes we'll do a dose reduction in that particular patient. So that's our experience here. And I'd like to hear from my colleagues if there's something else, or Anne-Marie, if you're aware of anything else from your patient perspective or what you've learned from those that you've interviewed.
No, I wouldn't know anything about dose. I wouldn't even pretend to know about it, to be honest. But it's all I know is that particularly on DOACs, that it's really important that the patient understands the kind of medication they're taking, how important it is to take it at the exact time every day. You know, the fact that whether, depending on the medication you're on, that it either has a 12-hour or a 24-hour efficacy. So we have on our website, thrombosis.ie, a small little DOAC video, which is designed by a pharmacist in St. James's Hospital, with Bayer, I think was. But it's a little 2-minute video that really gives people an understanding of exactly what they're taking. And I think that because anticoagulation medication, I mean, it's they're dangerous drugs. We've got to be aware of what we're taking. They interact with other things, but to take it properly so that you stay in range, so you're safe and are not going to get a blood clot, you're trying to protect yourself. So there's no point in taking it every other day and you're out of range then every other day, you know. So, but people don't automatically understand that. And I think physicians should understand that patients don't know that they have to take a medication. If they miss one, they're not to just take 2 the next day. You know, you know, it's really important. So understanding exactly what you're taking is crucial. I think that's a message that we need to get through.
Yeah, I think that's really important. So it's not just about the signs and symptoms of thrombosis, but also understanding how we treat them and the medications that we use, and the importance of taking them around the same time every day, depending on which preparation of blood thinner that you're using. So that's a really good point to emphasize for everybody. So making sure you understand the treatment you're on, why you're on it, and complications to watch for. So that's really important. Thanks for highlighting that.
I don't have a lot to add. If you just want general experience from our institution, it's probably very similar. We used to dose reduce pretty religiously based on the clot trial, but certainly with some of the more recent data suggesting that there may be more patients, particularly the ones who don't bleed as much, who might recur with a dose reduction and then they end up getting their dose increased back to their original weight-based dose either way. We've been a little bit more relaxed now, and we don't dose reduce everyone uniformly anymore. Particularly people we think are much higher risk for clotting, we leave them on the full dose. Patients who we think are high risk for bleeding, we might still dose reduce. And definitely if someone clots through whatever dose they're on, whether it's a lower or the regular dose, we will also increase the dose of their blood thinner to try to recapture control. And it does seem to be quite successful. There have only been a very small number of patients who have had to have more than one dose reduction before they start to do well again. It's a little bit unpredictable, unfortunately. It does depend a lot on what type of cancer you have, what types of treatments you're on, and your own personal clotting risk. Some patients may have a family history of clotting or other things that make them at higher risk. So I wish I could give you the black and white answer, but it's a little bit gray. So definitely discuss with your doctor if you have any questions, and your case may be a bit different than the next person beside you.
Yeah, and I think that's important too. Yeah, I think it's important to know that the way your cancer therapy is somewhat individualized to you, so is your cancer-associated thrombosis therapy. So we try to work with whatever treatments you're receiving for your cancer, and we try to balance those things, because we don't want our treatments to interfere with your cancer therapy. That's something that patients don't want, and we don't want that either as your doctors. So we want to make sure that we're all working together so that you get the best treatment for your cancer and for your clot. That's great.
There's a question here about how do your cholesterol levels affect your clot risk? Or just in general, from venous thromboembolism, from a VTE point of view, there's not a huge impact from cholesterol. Cholesterol's much more important when we're thinking about arterial clots rather than venous clots. So I wouldn't worry too much about that.
That's great.
Can I just say, we've got a patient who has cancer, and then we've a patient who's cancer that's after getting a blood clot. So now we've got the cancer treatment, then we've got thrombosis treatment. But it's not just the medication that's going to help the recovery of somebody who's had a blood clot, whether they've cancer or not. We've got to look at the whole picture. We've got to have this physical recovery, psychological recovery. It's really important that cancer patients know, and all thrombosis patients know, that as soon as their medication is working, within a few days, at least a week, they should really get up and start their recovery. They should get back walking, cycling, swimming, get that blood flowing into the lungs, into the arms, into the limbs, and not be afraid to move. And the reason I say this is because I was one of those people. I was terrified to move. I thought it was like playing Russian roulette, like if I move, if I don't move, will it move? If I move, will the clot travel? What do I do? And because I wasn't educated on my first clot, I was just absolutely terrified. And it did more damage than good, because it's so important to not to think like a sick person. In order to have the best outcome, you've got to get moving, get going, try and get back to normal and get moving, and don't just lie like a sick person in a chair, or, you'll do more damage that way.
That's a really important message, Emery. Thank you so much for reiterating that. And I think it's a great opportunity for us to summarize for this evening. So it's about the patient, it's about their cancer. the therapy for their cancer, the therapy for their blood clot when it's diagnosed, but also focusing on those non-medication aspects that we need to provide care for patients. And so I think that's a really great place for us to conclude for tonight's program. It's really been a pleasure to work with you guys this evening. And on behalf of Thrombosis Canada, World Thrombosis Day, and Thrombosis Ireland, I think this was a really successful evening. So thank you all for participating, and for our colleagues that joined us and our patient participants that joined us this evening. Thank you so much. I've learned a lot from everybody this evening, and again, this recording will be posted on Thrombosis Ireland and Thrombosis Canada websites next week. So thank you very much for everybody, and I hope you all have a great day. Thanks so much.
Thank you.